Today we're going to run through a tutorial on how to perform a femoral nerve block using point-of-care ultrasound. You may ask yourself the question, why regional anesthesia? Why take the time to learn how to do a femoral nerve block when I can just give my patient morphine? Well, it's a good question, and it's a question that limits a lot of physicians in our country from learning this procedure. You may also ask yourself, well, why ultrasound? Back in the old days, we used to just use a blind paresthesia technique, or even more recently, a tactile double pop fascial block. Isn't that just as good? Well, let me give you 3 reasons why I believe that an ultrasound-guided femoral nerve block is the most advantageous and optimal means of approaching the patient who presents to the emergency department with significant upper leg trauma. Well, first of all, they're very safe. Comparing regional anesthetic blocks to the less desirable systemic opioids, we can avoid unwanted side effects such as hemodynamic instability, respiratory depression, delirium. This is especially important in difficult patient populations, such as the elderly, those with underlying cardiopulmonary disease, or even those with opioid intolerance or allergies. And when we compare ultrasound guidance versus the historical techniques of blind paresthesias or tactile double pop fascial blocks, we begin to understand that variations in human anatomy and failure to visualize the needle tip prior to anesthetic deposition can potentially be very harmful for our patients. Number 2, they're effective. When we compare ultrasound guidance versus the historic localization procedures, the evidence is clear. Ultrasound guidance enables lower doses of local anesthetic to be used, with improved block success rates. There's faster onset of sensory blockade and prolonged analgesia duration, not to mention less systemic opioid use. So then let's get to my 3rd point. It's easy to learn. I promise you that if you just give me 5 more minutes of your time, I will be able to teach you how to perform an ultrasound-guided femoral nerve block with confidence. Step 1. We need to have a knowledge base to safely perform this procedure. I draw your attention to the lumbar plexus. The lumbar plexus is made up of exiting nerve roots from T12 through L5. The ventral divisions of these nerve roots then form peripheral nerves that innervate the lower extremity. Now, in the emergency department, we're most interested in nerves that innervate the anterior upper leg, and that's because these nerves are most accessible to ultrasound guidance. As such, I would like to draw your attention to the femoral nerve, the lateral femoral cutaneous nerve, and the obturator nerve. These are the 3 that make up the historic 3-in-1 that cannot be blocked in a single shot. But with present-day ultrasound technology, each can be blocked individually with separate ultrasound-guided attempts. So at this point in the tutorial, you should understand the relationship of the lumbar plexus to the peripheral nervous system of the lower leg, and specifically that in the emergency department, we're going to target the femoral nerve as it innervates the largest portion of the lower leg. So this leads us to the final piece of knowledge that's required to understand completely prior to initiating a femoral nerve block. And that's how the femoral nerve anatomy relates to structures around it. And for that, I'll draw your attention to this schematic that shows how the femoral nerve relates to both muscle and vascular structures at the level of the femoral crease. Most of you are very familiar with the anatomy of the femoral crease. So let me just highlight a couple key points that are really important when we perform a femoral nerve block. For medical school, you'll remember the acronym NAVAL, which helps us remember that the femoral nerve is the most lateral structure of the neurovascular bundle. It sits upon the iliacus muscle and is encased by the fascia iliaca. 1 to 2 centimeters above is the fascia lata. This will be the first fascial plane that your needle will penetrate. So now that we know our anatomy, it's time for step 2. Who do we do this block on? Let's look at the indications. Here's your list. Femur fractures, soft tissue injury of the anterior, medial, and lateral aspects of the upper thigh, as well as patellar dislocations. Who not to do it on? Well, the patient that says no, of course. The patient that has allergies to local anesthetics. Someone who has an infection, wound, or burn over the femoral crease. And then a couple relative contraindications. That'd be anticoagulation and a previous femoral bypass. All right, it's time for step 3. Let's gather our gear and let's get after this. So what are we going to need? Well, we're going to need a surgical marking pen for our surface anatomy landmarks. We're going to need equipment and anesthetic for skin infiltration at the site of the injection. We're going to need a 3.5-inch 22 gauge blunt Whittaker needle to actually perform our block with. We're going to need a 20 cc syringe that's going to be filled with 10 cc's of 2% lidocaine plain and 10 cc's of 0.5% bupivacaine. Grab a connector tubing, prime it up, and you're ready to go. All right, next you're going to grab your ultrasound machine and select your high-frequency linear access probe. Whether or not you choose to perform a sterile setup is really up to you. There's no great evidence to suggest that it's better or worse, but I found in the beginning stages it makes it a little bit easier to be able to pick up and put down your equipment at the bedside if you're struggling with the technical aspect of the procedure. Next step, patient positioning. It's pretty straightforward. You want to have your patient laying supine with both legs extended. If they're obese, you can choose to put a pillow under their ipsilateral hip to help expose the femoral crease better. Step 5, surface anatomy. Once you have your patient positioned, prepped, and draped, you want to start by identifying the course of the inguinal ligament. It runs from the ASIS to the pubic tubercle. Next, palpate and course the outline of the femoral artery. Recall from our anatomy lesson that the femoral nerve lies lateral to this position, so mark it with an X. Once that's accomplished, you want to infiltrate local anesthetic at the site of the X, as well as extend it laterally, because I've found that the trajectory of your femoral nerve block needle needs to be quite low in order to hit its target. Step 6, sonoanatomy. We're going to make this step very brief and focus in on just the femoral nerve. You can see that it's a hyperechoic structure that lies lateral to the femoral artery. Most of the time it's triangular in shape and quite dense, making it easy to identify. However, there are occasions when it can be hidden and abnormal, as in this example, where it's lying elongated and flat on the surface of the iliacus muscle. If unidentified, it would be quite easy for a beginner to potentially put the femoral nerve block needle directly through this nerve belly and harm the patient. All right, step 7. It's time to perform the block. This is when your procedural and technical skills get put to the test. In this next screenshot, I'll show an ultrasonographer performing a femoral nerve block. This is the needle. He's already penetrated the fascia lata. This is the fascia iliaca. This is the femoral nerve. This is the local anesthetic. And this is the iliacus muscle belly. Let's look at this one more time. The needle tip has already penetrated the fascia lata and is just about to penetrate the fascia iliaca. The operator is directing his needle tip to the inferior aspect of the femoral nerve and is infiltrating local anesthetic to lift it off the surface of the iliacus muscle belly. Could you imagine doing this blind now that you can see? Amazing. So it's not all just rainbows and butterflies, is it? No. There's always drawbacks, potential complications when you're performing a procedure. Let's review a few. Local anesthetic systemic toxicity occurs with an inadvertent infiltration of local anesthetic into the circulation. This is bad news. Consider adding epinephrine as a marker for it. Infection. Only some case reports in the literature with this type of procedure, but it can happen. Bleeding, an inadvertent puncture of the circulatory structures, not good. Finally, nerve injury, not likely under ultrasound guidance, and can be even reduced further by using a blunt needle tip that pushes the nerve away rather than penetrates and causes harm. All right, time for a quick review. Step 1, know your anatomy. It's the basis for this procedure. Step 2, know your block. Who do you block? The indications, the contraindications. Step 3 and 4, equipment, positioning. Step 5 and 6, surface anatomy and the corresponding sonoanatomy. Step 7, the technical performance, the fun, and finally the complications. Anticipate them and know how to manage them. Well, there you have it, 7 easy steps to the femoral nerve block. I hope you've enjoyed this tutorial and that you'll use this skill on your next shift in the emergency department.